You've got to understand your anatomy. So if you've got a neobladder, for instance, you need to understand that there'll be a chimney there. You need to understand how your reconstructive surgeons will have plumbed the ureters back into that, because they will tend to do it in a standard way in your own hospital. My personal game plan often is to try from below, to try and access the patient retrogradely. So often you can get a wire up from below, and if you can get a wire up from below, then normally we're able to gain access retrogradely. It's certainly worthwhile trying a retrograde access in the first instance. As you can see in this case, where we have a patient with a transplant kidney. So this is a case of a 45-year-old lady who had a history of psychoureteric reflux. She had a transplant about 7 years ago, and she had a CT scan follow-up for an unrelated complaint. And the CT scan showed, here you can see the native kidneys which look atrophic, and then if you look here in the right iliac fossa, you can see her transplant kidney. And as we follow it down in the transplant kidney, you can see we're going to reach some stone in the lower pole of that kidney. So not a very big stone, but certainly a stone which, given the fact it's effectively a single kidney, we're going to need to treat for her. Managing these patients who've got a reimplanted ureter can be challenging, but I think it's certainly worthwhile trying to do this. In fact, a colleague at another hospital had attempted stent insertion on this patient and found that it wasn't possible, but we thought that we would attempt retrograde access to this patient to see if we could get the stone treated. You can see on this plain KUB, the stone sits here in the right iliac fossa, and you can see here that we're passing a sensor wire up into the kidney. You can see there we've got a short access sheath, a 28 centimeter access sheath, and then we've got a lovely retrograde which shows the transplant kidney in the right iliac fossa, and of course the stone, as you might expect, is right in this most dependent calyx. But we're able to reach this. This is a litho-view ureteroscope. We've passed that up through the access sheath. You can see we've got a 180-degree bend. We're able to access the stone retrogradely, treat it with a laser. The fragments are actually moved then, further treated and dusted, and the patient at the end is then stone-free. We've stented this patient post-operatively, but she was discharged home the same day and she was stone-free at follow-up. Take-home message is to be flexible, to be sure that you have a good outcome for the patient on hopefully a single sitting. So by all means try retrogradely, but be prepared to fail retrogradely if you don't manage, and think about an antegrade approach if it's required.